So let's move forward. I'm going to present now Dr. Marcell Szász, oncopathologist. You all know him probably. He comes from Hungary, and he's going to speak about modulated electro-hyperthermia treatment in the therapy of inoperable pancreatic cancer patients, a single-center case control study. So please, if we can put his presentation. Great.
Good morning. Can you see and hear me?
Yes.
Excellent. Thank you. I hope so that it will work out as all the presenters could manage as well. So it's always a pleasure to talk before the coffee break, and as I hear it's being prepared outside. So don't keep yourself back. We were severely hit by this COVID situation also in Hungary, not as much in the spring as now. And we were still packing together our stuff this morning, and we are closing down again due to the COVID, and oncology is happily sharing the building with pulmonology. Thus, the COVID situation will hit us hard. But we were able to work all year actually, and we were continuing the treatments, even though for a limited number of pancreatic cancer patients and some others. So if we look at the cases worldwide, pancreatic cancer may not be one of the most frequent ones, but still, due to its nature of progression and the poor prognosis, we see that it's one of the most frequent tumors in Central Europe, and the mortality is not decreasing. On the contrary, if we see a prospect and we look into the future, we see that a high number of cases will actually emerge. In a few decades, we will double the cases at least, and there will be an overall change of at least 75% to 80% also in pancreatic cancer cases. So if we look at this tumor, we know it's progressing behind the retroperitoneum with the dense stroma and very, very ugly looking adenocarcinomatous cells, which are in theory really resistant to systemic treatment options. And also, if the location is infiltrating the big vessels, then the removal by surgery is also limited. So what underlies this is the background. This is the important gene here. The KRAS gene is responsible for the oncogenic events behind this tumor, and also P53 is mutated in most of the cases. So these two players are actually a death sentence to the patients. However, there is a small minority with other driver mutations, and those can have a different prognosis, but we actually didn't see that. Even in wild-type KRAS and P53 cases, we see the same prognosis. So if you look at the literature, there were some pancreatic cancer studies before from Romania, a phase 2 study, when they administered hyperthermia treatment with intravenous chemotherapy of gemcitabine and oxaliplatin during the days when the chemotherapy was administered. So this is Monday, Wednesday, and Friday, for instance, with hyperthermia, and this is a Monday treatment with the infusion, with a 1 week break, and then on the 15th day the treatment continues They did see a significant overall survival benefit of these patients in about 26 cases. In another study, they also have seen the profit of modulated electro-hyperthermia in patients with metastatic pancreatic cancer cases. However, these patients were heavily pretreated and failed the conventional therapies before. If you look at the summary of the treatment with hyperthermia and without, and the SEER database and Eurocare database, we do see a high enhancement of survival. So the scale is the survival in 1 year, that most of these patients survive this statistical line. So we only treat in our center the torso of the patients. Yeah. So we had a pilot period when we were treating breast and gynecological cancers, urological cancers, renal cancer, and also some sarcomas, actually, with a few lung cases. But the majority of our cases comes from the GI tract, colorectal tumors, and the most frequent cases are pancreatic cancers of inoperable fashion. So we had a small pilot study back in 2017, and we performed a case control study, which I will present now, which eventually will lead to a randomized controlled trial in a certain setting of pancreatic cancer cases, hopefully in the near future. But this is how we were affected now. This is being questioned, but we hope that we can continue that. So we performed a retrospective single center case control study of 78 pancreatic cancer patients. All of them were diagnosed between 2014 and 19, and our case group was comprised of 39 inoperable pancreatic cancer patients. We closed the data collection just before the COVID hit Hungary in end of January, and each patient was actually matched to a control patient by age, sex, and chemotherapy, which was received during the treatment with hyperthermia. And we also compared the presence of ascites and the presence of distal metastasis in a restricted fashion. So the treatments were between 2016 and 19, meaning that in some cases there were years passed after the diagnosis and the treatment was actually started. So it's still a various group of patients. The instruments we used were the instrument 2000 and 2030, and at least 19 treatment sessions were administered for the patients. So we do this similarly to the Volovat paper. So we do a 2 or 3 times treatment a week, Monday, Wednesday, and Friday for these patients. During these occasions, we, in the starting phase or training phase, we start from 50 watts and we reach 100. And then when the patient is accommodated and feels comfortable with the treatment, we start with from 100 watt and go up to 150 watts during 1 hour. So we continuously treated the patients as long as they could tolerate the treatment. So that's going to change in a clinical trial, of course. As systemic treatment, we had a FOLFIRINOX chemotherapy and gemcitabine-based protocols with or without platinum agents or 5-FU. So we calculated the overall survival between the date of diagnosis and death from any cause. And the follow-up was closed in January, and these cases were censored who were alive at that time. So we just performed the Kaplan-Meier analysis with the usual log-rank tests and statistical methods which are commonly used. So as the patients it was a case control study, the gender and operability were matched, and the same with the chemotherapeutic regimen which were used for these patients, and we didn't observe any kind of significant difference between other parameters of the patients. When considering the overall survival, it was also similar. However, we did recognize a trend. If we looked at all the patients, we did see that the modulated electro-hyperthermia treated patients have a benefit over the control cases. And when we checked for the presence of metastasis, it turned out to be a significant overall survival advantage for those who had a metastatic lesion. These were mostly lymph nodes and liver cases, and on many occasions both of them were apparent in one patient. Interestingly, it's not only abdominal but also supraclavicular and other locations of lymph node metastasis in a single patient. In the non-metastatic tumors, you can see that the case numbers are much lower, so statistical difference or any kind of conclusion is, I think, limited. So we went for the ascites formation. Huge ascites or larger amount, of course, is not treated, but a limited amount we always try the ascites patients to treat, and there was no benefit actually when we looked at this case. But when we look at the other group where there is, of course, no ascites, we do see again a trend, although it's not significant, but the trend is towards the modulated electro-hyperthermia to provide benefit over the control treatment arm. So when we also see that at the numbers, when we have over 20 cases, we do observe a trend in both the settings. So we try to understand this, what's in the background for these tumors, and we divided the cases into 3 groups. The red ones are the short survival group, the green is the long survival group, and the black is in between. We didn't really observe any kind of significance between these cases. Of course, with time, there is a smaller rise or lower or decreased tumor marker setting regarding the CA19-9 in these patients. This is just a different display on the right when we were calculated from the first event, the numbers. So just look at the absolute numbers on the left in each case. We also had a few cases. 0 time point means when we started the treatment. So we wanted to look whether there is any predictive power in this means in the cases, but we didn't observe actually any predictive power for CA19-9. We performed the same for the CEA. We can nicely see how the numbers rise, or for the long-term survivals they stay low, but we didn't see any significance here either. So it seems that with tumor markers, we cannot really predict who is going to respond or not to the treatment. We need to look for other options. So as we have seen that modulated electro-hyperthermia is also an immunomodulator, and the significant part of its effect comes from the antigen presenting and an immunomodulated cell death. We looked at the regular lab results of lab testing of white blood cells and the subgroups of that, and each line represents 1 patient. So we didn't see here either any kind of significant difference between the groups. Of course, the red ones have a shorter time we could follow, and the black ones the longer, and the green ones the longest one. So we went for the lymphocyte counts before and after treatment, and also we wanted to look at whether there can be any pattern recognized in this setting, but we didn't really observe anything that would be striking. However, we see that there is a significant intra-patient variation when we take the blood tests and then we look at the cases. So before we have profiled with fluorescent flow cytometry the lymphocytic counts in the patients, we have to be careful when we look at that, and we have to always bear in mind that the time is, sometimes we can take a sample when it's low, sometimes when it's high, and we will look at this recently with the support of deep learning and machine learning algorithms, where we can discover anything further in these cases. So the same for monocytes, a huge difference in intrapatient counts during the treatments was observed. So despite this year, which was not so lucky for us, we see that the work is actually rewarding, and we do see an improvement in overall survival for the inoperable pancreatic cases, especially when metastasis is formed and there is no ascites in the abdomen. So the mechanisms and the prediction to response will be further investigated, and just now we are trying to organize our randomized clinical trial for the gemcitabine plus NAB paclitaxel treated inoperable metastatic pancreatic cancer cases. And we are now merging the data, and hopefully an AI-based evaluation will shed more light on the underlying biology and the causes of difference between the responders and non-responders soon. Thank you very much for the attention and your time.
Great, thank you, Marcel. Very, very interesting. I don't see questions, so we are very late. So just one comment from my own. I agree with you that hyperthermia in pancreatic cancer has an important role. We see impressive results in patients. So I think we need those trials